And thank you all for giving me the time to present our talk on leading the way in improved cancer care in molecular imaging and theranostics. I don't have any conflicts of interest to declare. So for the objectives of this presentation, we're going to start by explaining the principles and history of molecular imaging and theranostics as it relates to cancer care. Then we're going to discuss the need for integration of these techniques into regional cancer centers. And then Dr. Zukotynski is going to take it over to identify some exciting and emerging trends and advancements in the field. So Dr. Paul did steal one of my slides here by introducing, and I think you probably heard in a lot of the talks today, what theranostics is. So I'll just reiterate again, it's the combination between molecular imaging and then targeted radionuclide therapy. And so what that does when you combine the two is it opens up the opportunity for precision medicine. And so we're really starting to see an increase in this field. You can see on the graph on the right, that's not necessarily a graph of what we're experiencing in Canada, but we are starting to see, especially with the approval of lutetium PSMA or Pluvicto, we're starting to see that pressure and increase in demand. So to go over some basics on cancer care, so you have your pillars of cancer care, and 4 of which fall under the umbrella, for the most part, of regional cancer programs. So you have surgical oncology, you have radiotherapy or radiation therapy, medical oncology, and immunotherapy. And molecular targeted therapy is another one of these pillars, but oftentimes we fall on the outside of that umbrella of cancer care, and that's the main point that I want to highlight with this slide. And so here I know that this slide is busy and you probably can't read the details, and I don't need you to get my point across. So this graph on the right is one patient coming to LHSC with metastatic castrate-resistant prostate cancer. So I just picked one disease site that could either go one of 2 streams. So on the left side of the diagram, you can see that patient. They'd be traveling through the London Regional Cancer Program and receiving a chemotherapy agent. On the right side would be that same patient coming through molecular imaging and theranostics to receive that lutetium PSMA. So the points that I wanted to note here on the far left and far right columns are associated documentation. So those items in red that you see on the left side with the patient traveling through the regional cancer program, those are things that are being documented in the electronic health record. Those are surveys that the patient's receiving to help them along their journey. The next thing I wanted to point out is those circle bubbles in the middle. So those bubbles relate to patient supports that they receive. So that can range from home care to social work to dietary support. So if you look at those things on the left side, those are all things that patients are receiving, and it's very evident that on the right side of that diagram, that same patient will not receive that same sort of documentation and support. Now the last thing I want to identify is that little yellow bubble, and although it's small, it's extremely important. So what that yellow bubble signifies is that all treatments that occur in a regional cancer program are rooted in quality assurance and quality control. So once again, that's something that we're missing in molecular imaging and theranostics. So to summarize this slide, I had the 2 pictures put on the side. So it's very clear where we are. It's very clear where we would like to go. So it's a matter of figuring out how to get there. And so we know that diagram exists. We know that's the way it is. But oftentimes it's important to go back to the literature to ensure that what we're experiencing is matched in publications. So I'm just going to review some of them here. So the first being that a tremendous increase in demand for theranostic procedures can be expected. So that anticipation of lutetium PSMA, that's not something that we're making up. It's definitely something that's happening in other countries, and it's going to happen here. The next one is that, not surprisingly, currently the most successful theranostic centers are embedded in strong cancer centers. So now that I presented that diagram before, you can see why. If they are embedded in strong cancer centers, they have that associated documentation, they have those patient supports, and therefore they become successful. An active presence and participation of the nuclear medicine specialist in the multidisciplinary team is mandatory. Now, this is something in London that we're particularly good at, I would say. We're on our way to having the nuclear medicine specialists be a part of disease site rounds. However, there's rounds that occur that we are not a part of and we probably should be. So we need to make sure that we're continuing to advocate for that. And the last quote on quality control is sort of a slam dunk quote. I think if I ask anyone in the audience if you think that there should be quality assurance and quality control surrounding a cancer therapy, you'd say yes. So that's confirmed. A well-documented program for quality assurance and quality control is essential. So what are we doing about it? So we saw the LHSC Academic Realignment Initiative as a way of gaining resources to address some of these concerns. So we put forward a proposal to establish an academic partnership in molecular imaging and theranostics between nuclear medicine and the London Regional Cancer Program. So the goal of this, or the underlying tones, was to create research and education opportunities within molecular imaging and theranostics. But while we were doing that, we wanted to make sure that we were setting it up in a way that we were going to address those gaps in the first diagram that I showed. And we don't have to necessarily be novel in every aspect of this. There are countries that are particularly strong in molecular imaging and theranostics, that being Australia and Germany. So we don't have to necessarily recreate the wheel. Canada does have a unique healthcare system, and therefore we need to create things for our system, but we can look at their successes and failures. So the next slide is on breaking down those silos that many other presentations have touched upon. So one of the first things we did was develop an MIT steering committee. And so what that committee involves is administrative and physician leadership from both the cancer program and molecular imaging and theranostics, as well as medical imaging. And so the idea with that committee is to guide the direction of our program. And we felt that if we had all of those stakeholders engaged in our program, it'll help us push some of these initiatives forward. The next thing we wanted to do was to look at leveraging some strengths in residency collaboration. So nuclear medicine has a strength in interpreting functional images, and radiation oncology, among many other things, has experience with dosimetry. And so the two programs can leverage each other's strengths on that. So in radiation oncology, it's important that they understand PET-CT images and how to interpret them and see them. And they can learn that from our nuclear medicine specialists. And our nuclear medicine residents can then rotate to radiation oncology to gain that experience in dosimetry, because we know, like programs like Y90, that dosimetry has already started, and we need to make sure that we have that strong foundation. The last thing we did was that we launched in November a Theranostics multidisciplinary conference, and this is something new, I would say, to the field. And so this has a lot of different specialties come. So we have people from the cyclotron, we have imaging sciences attending, the various cancer center disciplines like medical oncology, radiation oncology. And so these rounds, these theranostic multidisciplinary rounds, have been a great opportunity for all of these different disciplines to come together to talk about how can we push this program forward, how can we collaborate. We talk about clinical trials that are potential interest to us. And then also what we're expecting to see is that right now I would say it's mostly academic, but we're going to start to sprinkle in some casework. And going back to that first diagram that I presented, so to provide and illustrate a use for the MIT steering committee that I had just mentioned, we presented these gaps to the cancer care leadership, and we came to them with a proposal and some recommendations on how we could address those gaps. And we came to an agreement on a mutually beneficial arrangement. And so what we decided on and what we agreed on is that the London Regional Cancer Program will provide resources to nuclear medicine or molecular imaging and theranostics to address these gaps. The beneficial part from the cancer center perspective is that we are going to run that clinic out of the nuclear medicine department. So it may not be common knowledge, but it may be that the cancer clinic is very constrained on clinic space. And if you think back to that graph that I first showed of that increasing exponential trend, if we were to operate out of the cancer clinic, we could run into a potential shortage of space, even more so than exists today. And going to the yellow circle again, which is that quality assurance and quality control aspect, we have reached out to the Canadian Association of Provincial Cancer Agencies and Ontario Health to pitch them an idea, and if I can simplify it. So we pitched to them that there is a need for quality assurance and quality control in radionuclide therapy. There are none that currently exist. And LHSC is in a very good position to be able to lead this work. And so what we proposed, and we have endorsement from various provinces across the country, is to lead pan-Canadian quality assurance guidelines for radionuclide therapy. And with that, I'm going to pass it over to Dr. Zukotynski.
So thank you, ladies and gentlemen, and thank you, Stephen Nelli, for that beautiful start into molecular imaging and theranostics. So without further ado, I always include the Brigham and Dana-Farber on my first slide because it reminds me that I traveled all the way to Boston to be taught pretty much everything I know about PET-CT from a man who came from Winnipeg, and to dedicate all of my talks that include PET to him. Disclosures, I've worked for several companies over the years, more as a consultant or on advisory boards. And I thought I would keep it simple. Let's start with imaging, and then we'll talk a little bit about therapy. So, why am I so interested in molecular imaging and nuclear medicine in particular? I started out life as a radiologist, ran into nuclear medicine almost by accident, I would say, and never looked back. And I would say the reason for it is that most of radiology is black and white. Nuclear medicine glows, and it can glow all the different colors of the rainbow. And one of the beautiful things about nuclear medicine is that you need good radiochemists, because you need to be able to put together radioactive drugs that have met legal requirements for administration to patients, and those drugs have to target specific either metabolic processes or proteins, but it's really good if you know what you're looking at. Now, part of the problem is that if you want to be able to produce these drugs in bulk, you kind of prefer if they're not quite so specific, because then you have to make drugs for a particular cancer type, versus if you can give everybody the same drug, all of a sudden you have your bulk that shows up. And that's why, although I list all of these drugs, I will come back to the workhorse, which is FDG. But before I go on to that, I want to make a mention of why PET. Why are we so interested in it? And I would say this was a paper that was actually many years in coming. And what it was doing was comparing sodium fluoride PET, which are these images, with routine skeletal scintigraphy, which is on gamma cameras. And the bottom line is that for someone like me, if I read a sodium fluoride PET CT, I kind of feel like I'm reading my routine bone scan wearing my glasses. It's just a lot easier to see all the details. Now, that doesn't mean that you can't do a good job with scintigraphy. You can. It's just that if you want to see each individual site of disease, and you also get a CT into the process because it's basically impossible to buy a PET alone nowadays, then you have an awful lot of information, and your resolution is typically on the order of 4 millimeters nowadays with the equipment we have, versus closer to 1.5 centimeters when you're dealing with SPECT. It does to some extent depend on how avidly the radioactive drug is taken up, but your resolution tends to be a lot better. The other question, and that's the reason I put this in, is because at the end of the day, you always have to go back to first principles. So what is your drug targeting, and what is the clinical question you actually want to answer? So although FDG tends to be taken up by most cancers, and the reason for that is just interesting. As most of us who have tried to lose weight know, sugar is bad for you. Typically, the nastier the cancer, the sweeter the tooth. And it's almost a universal truth. So I would say that FDG is usually very good at depicting sites of cancer, but it may not necessarily show you how good the response is. And so in this case, I'm showing you that you can actually gauge, this is an FDG scan, this is an FLT scan. FLT used to be a little bit more popular in the old days. This was at baseline, this is at follow-up. And although your sites of disease are more FDG avid, if you look at the FLT, it actually shows the response better. So it becomes a little bit of a question of what is the goal of your imaging? What are you targeting and what are you trying to see? This is what a normal FDG biodistribution looks like. Since the brain has to use sugar, you usually see intense uptake in the brain. That's why I like to get a few slices of the bottom of the brain on any PET I do, just because then I know a little bit more about the biodistribution. Usually have mild uptake in the aorta, spleen, and liver. Tends to be moderate in the tonsils and the submandibular glands, and variable in the heart muscle and brown fat. You have to know what's normal to know what's abnormal. So here I've given you a picture about a normal liver and spleen. You can see there is some diffuse uptake in the liver, uptake in the spleen. The spleen is less intense than the liver. And this is why all the hype about PET. Because this liver was diffusely involved with metastatic disease. And I'm sorry, if it's 2 in the morning and you're looking at it from across the room, you can see there's something wrong with that liver. I kid you not, even on a contrast-enhanced CT, they couldn't be certain that there was metastatic disease involving the liver in this case. So, and in this case, it's disease involving the spleen. And again, you can see it from across the room. So it tends to really point out where you want to look. Now, why all the hype about PET-CT? So PET has existed for many years, but it really took off when it was married with anatomic imaging. And what was the reason for that? Because PET alone doesn't give you good anatomy. Nuclear or radiology often has tools like CT and MRI that give you really nice anatomy. So now you know exactly where what you're targeting with your radioactive drug is. And that makes all the difference. And not only that, but they complement each other. So I think of it a bit as a marriage made in heaven, because, for example, this was a patient with esophageal cancer at the gastroesophageal junction. We can see that there's intense uptake on the PET. You would never call it in a million years on your diagnostic CT. However, if you look lower, there is an incidental renal cell carcinoma, and about 70% of renal cell carcinomas have uptake comparable to normal renal parenchyma. So you call it on the CT, you don't call it on the PET. So the two are extremely complementary, and it's really important to look at all the images. So where does PET-CT fit in today? Probably the oldest indication was for the solitary pulmonary nodule, and the idea being not necessarily in my books that if something is avid, it's cancer, because that's not necessarily true. Infection can be equally avid. But if it looks nasty and it takes up cancer, the more intensely avid it is, typically the more aggressive the malignancy, the less time you have to deal with it. The other thing that it is incredibly helpful for is M staging, so looking where the disease has spread. And that's largely because, as you can see again here in this case of lymphoma, you can often see the disease from across the room. So then you can hone in on your anatomic imaging, but it lights up, so it's very, very pretty. What cancers is it useful in? It's almost all of them. And the further we go, the more we see that it is pretty well useful across the board. There are certain things you have to keep in mind. So in the early days, they did studies saying it wasn't particularly good for looking at small disease spread, say to axillary lymph nodes in breast cancer or to regional nodes in melanoma. Well, if you're below the resolution of the system, you're probably going to have a hard time picking it up. But is it very good for looking for distant spread? It really is. If it's very small, it may be tricky unless it's very avid, but it's generally very helpful, and it's very helpful for looking at response. So here we can see not only has the disease basically gotten better, but there might be a little bit of residual disease still left, and you know where to look, so you look much more carefully at those sites. As with anything, there is no silver bullet in medicine. So even though something might be avid, it doesn't necessarily mean that it's cancer. It turns out that inflammation and infection also take up sugar or radioactive FDG. So here I'm just showing you a case that this is diffuse uptake in the spleen in a patient with hemolytic anemia. This is uptake in the spleen with a patient who had splenic involvement by lymphoma. This was a 17-year-old football player who was very popular with all the cheerleaders, and there's no way to tell without a biopsy or additional testing that this is a case of infectious mono. It's not a case of lymphoma. So it tells you where to look. It's extremely helpful for telling you if you have cancer, whether it's more aggressive or less aggressive. It can be problematic in that not everything that shows FDG uptake is cancer. The other thing that's very interesting, and this speaks to what Steve was talking about, which is the need to do quality assurance and to do standardization. So when I was in Boston, actually, my program director decided that he wanted to see how all the pediatric hospitals were dosing their children in terms of radioactive drugs. And he did a survey across, I think it was 10 centers. They were all tertiary care pediatric centers. And he discovered that the difference in radioactivity was almost tenfold between them. So it was a crazy difference. And that sparked in nuclear medicine a little bit of this go gently into this good day. Don't overdose people if you don't need to. But you have to keep things in perspective. So it kind of comes back to where I said at the initial point, you always have to go back to first principles. So when I first came to Hamilton, I kid you not, we were reading some PET scans like this. The patient did not fit into the scanner, and the patient was huge, and the images are just not that pretty. So you had to play with the parameters, which they did, to get a very pretty image such as this. So you want to be a little bit careful about your quality assurance, follow your guidelines, and then look and see what actually works best. So quality assurance really is key. And then for opportunities, well, I would say the opportunities in nuclear medicine, molecular imaging, and theranostics are enormous. I always show this because you'll see on the next slide, but the bottom line is one of the things that can be a problem for us is metabolically active brown adipose tissue. It turns out there are two types of fat. There's white fat and brown fat, and brown fat takes up FDG, particularly when it's turned on. It is typically bilaterally symmetric, and what's the problem? Well, the problem is that if you have a sea of metabolically active brown fat, it's kind of like I said, the FDG uptake shows you really where to look and where to look carefully. But if you remember in the old days where we used to highlight pages so that we would know where to look back, if your whole page is highlighted, it's very hard to know where you're going to look to find the abnormality. And this is a sea of metabolically active brown fat, and the only site of disease here is this tiny pulmonary nodule. It is avid, but if anything, it's actually less avid than the metabolically active brown fat. Turns out, and I kid you not, one of the first papers I ever wrote, they sent it back to me and said I had to quote the text from 1551, which was where it was first talked about. It was talked about in Marmots. I did get that text. It was in Latin. I had my mother translate it for me. And the bottom line is that we've long known about metabolically active brown fat. We think that it's driven by sympathetic release of norepinephrine. It may be related to diet, but how common is it really? Technically, as you get older, it does disappear. However, it also becomes more resistant to being turned on and off. And the bottom line is that correlation with CT is key. So if you know that it's fat, then you know based on your densities in your CT that you're looking at metabolically active brown fat. So you have to look very carefully. And this was a project we did where we found that simply if we turned up the thermostat in the patient uptake room when we gave them the radioactive drug, that the incidence of metabolically active brown fat dropped from about, I think it was 27% to 9%. And the reason I show this is when we talk about opportunities in nuclear medicine, this is scientific evidence that we should have a SPA in the nuclear medicine department. So on to Theranostics, and you've already heard some discussion about PSMA, so this is the lead into it. I got interested in prostate cancer based on this study. It was a gentleman who came in who had widespread bone metastases. They treated him with XL184, and within 6 weeks, he had nothing. Even the degenerative change looked better. And I got on the phone with the oncologist and I said, what the heck are you giving this man? And it turned out that the medication they were giving the man actually turned off osteoblastic turnover. And since a bone scan is taken up by osteoblasts and incorporated into the bone, they were treating the bone scan. So, in further research, it showed that it was partial treating of the prostate cancer, but partial treating of the bone scan. So, I said, okay, what can we get our hands on that we can use to image men with prostate cancer? In those days, you could get sodium fluoride. And this is just nice because it shows that sodium fluoride is actually a bone agent. It works much like your technetium 99 MDP bone scans. Basically, it's taken up by osteoblasts and incorporated into the bone. And so you're not imaging the tumor itself, you're imaging the reaction to the tumor. So you tend to see these rings of fire or these circles of uptake versus FDG, which is taken up by the prostate cancer cells themselves. It's just the majority of prostate cancers, when they're well behaved, show very minimal uptake. So it can be really hard to see it. So then the question became, well, can we use either of these tracers to predict how patients are going to respond, or are they going to live long? And basically what we found was that if they showed FDG avid disease, they did badly. If they had lots of bone disease, yeah, it wasn't good, but they could have lots of bone disease and actually do quite well. If they had FDG avid disease, they did badly. And that has played out, that's a bad prognostic marker. The problem is that we really needed a tracer that was taken up beautifully by prostate cancer cells. And we had to wait for that. But it came along, and this is one of the first images with PSMA, targeted radiopharmaceuticals, that we did in Canada. And it shows disease going all the way up to the Virchow node, and I will say all the disease above the diaphragm was unknown based on the standard of care imaging, which was a bone scan and a CT. And if you look closely, this is why it's so beautiful to read PET CTs, because you can see the site of disease from across the room. You would really have to be on your game to call that lytic disease. Really, truly, this is hard to call. And when you can have it highlighted, it becomes a lot easier. In fact, the only site of disease in this man that the radiologists were worried about was this one poor little bone island sitting here, which actually was not malignant at all. How good is it? It's very good. In fact, we found that up to 30% of studies, even with a very low PSA, will show uptake on PSMA PET. So now where are we in terms of Canada, Ontario? We're in kind of bad shape when it comes to PET scanners. And this is partially, again, why it's so important for us all to work together. So in all of Ontario, there are 14 PET CT scanners, and only 6 centers in Ontario are offering PSMA PET. London, according to CCO, has 1 scanner. However, kudos to you. Basically, I was told, to decommission one of your PET scanners, and you said that just doesn't make sense. So you will have 2 scanners. Hamilton has 2 scanners, but one of their scanners is PET only and dates from the 90s, so it's not very good. So I wrote with a caveat. UHN has 2 scanners, Sunnybrook has 1, Ottawa has 3, but 2 of them are dedicated to cardiac. Thunder Bay has 1, but they can't get their PSMA radiopharmaceuticals, so they wind up shipping their patients elsewhere for imaging. In terms of those that are coming on board, Sudbury has a scanner, Windsor and Mississauga has 2 in IHFs. These are not doing PSMA PET yet. They have 1 that's going in Barrie, 1 that's going in South Lake. These are anticipated to be up and running within the next 6 months. Kingston has a scanner, Lakeridge as well in 12 months. And the CCO plans to put forward an expression of interest for PSMA PET probably in the fall, so that additional centers might be coming online. This is very important because right now we actually have wait lists for our PSMA PETs that run into months. And that's a problem if you want to image your man quickly and then get him going in terms of treatment. And that's partially because of the cyclotron issues and how they can supply the radiopharmaceuticals. So DCF-PYL generally is coming out of Toronto. PSMA 1007 is coming out of London. And so once you're up and running, we're hoping that there will be more sites that will be able to use it. PSMA, gallium PSMA 11 is interesting, and part of that has to do with generators and who has access to generators. I'm told they're going to try and work that into the CCO mix. So when we look at prostate cancer, the question is, what imaging can we do? What imaging do we want to do? And I would say PSMA PET is very good at picking up sites of disease. However, If you have FDG-avid disease, these sites tend to be more aggressive. So in fact, there's a lot to be said for doing multi-imaging in these patients. Do we have the resources to do that? I would say not at this point. However, there is a possibility that going forward, we might want to try and do more imaging if we can. It's an interesting question and one that I think we'll see more of in the future. So let's get into therapy. The use of targeted radionuclide therapy, that's the use of one or more radionuclides for targeted therapy at the cellular or molecular level, leads to cell death by either direct radiation, crossfire, or the bystander effect. It's actually been done for many years. Thyroid therapy using radioactive iodine dates to the Second World War. In prostate, radium was probably one of the first to come up, and more recently, PSMA therapy. All you do is you change out the radioactivity so you can see it on the PET scan, and then you treat what you see. And this image actually made the image of the year at the 2018 Society of Nuclear Medicine annual meeting. And part of the amazing feature of it was not just that 62% of men had huge drops in their PSA following it, but there was a small contingent of men who literally would walk into the center palliative. They had so much disease and would walk out with nothing. And it was really amazing what can be done. Now, it doesn't work well in everyone, but in those that it works well in, it can work very well. Pluvicto was approved within the last year for the treatment of adult patients with prostate-specific membrane antigen, so PSMA positive metastatic castrate-resistant prostate cancer, post at least one androgen receptor pathway inhibitor and a taxane-based chemotherapy. The beauty of it is that it's relatively easy to perform. So they adopted an empiric dose, and that's largely because it's just easier to produce, I think, and to administer. I'll come back to that in a little bit. You give a total of 6 doses. It's a slow push over 1 to 10 minutes. You have to do laboratory tests. But in some centers, they actually have the patients in and out, and they almost do it as a conveyor belt. It can go fairly quickly. If you're doing it for research purposes, you want to take a little bit longer. Depending on the patient you see, you may or may not want to take more time to see how they're doing and whether things are going to work out. Regardless, it's a useful drug in our armamentarium. So I would say we live in very interesting times. A few of the recent seminal clinical trials with easy to recall names that have shaped the last decade of therapy. Can you imagine? 10 years. That's it. Alsimca was 2013. It brought us radium dichloride. The Netter trial in 2017 brought us lutetium dotatate. And the Vision trial in 2021 brought us PSMA therapy. So have we had radioactive therapeutics? Yes, we've had them since the Second World War, and they have changed the life of patients with thyroid disease and thyroid cancer. Now we have a chance to change the life not only of patients with neuroendocrine tumors, but of patients with prostate cancer, and that becomes a huge swath of the population. So this is an example of radium therapy where you can see a man who had prostate disease. Post-therapy, it looks a lot better. The issue with radium is that by and large, it's confined to bone. This is a case of a dotatate PET. And again, with dotatate, you usually want to do the PET in advance. And the idea is that you need to select the best patients who are going to respond to the therapy. So if your tumor is expressing the agent that you can then target with the therapy, chances are they're going to respond better. So we look and we see just how avid, how much radioactivity is it taking up. And if the tumor is taking up a fair bit, here we can see there's lots of disease, there's actually disease all through the body, we say they're probably a good candidate. And then what we can do, which is a very interesting thing, it's not done routinely, and the reason for that is that at the end of the day, you have to keep things simple. If you make things too complicated, it tends not to work in the long run. However, you can give patients a dose and then image them based on the radioactivity you gave them to treat them, and see what's the burden of disease, what is the radiation to the different organs, and how can we optimize subsequent doses so that we give them the maximal benefit with the minimal toxicity. It's tricky. People are still working on this dosimetry concept, but it's a very interesting idea, and I think it may be a way in the future that might become more common. This is just showing you the first patient we treated in Hamilton with the PSMA targeted therapy. You can see there's fairly widespread disease, all this black stuff, and there was disease on the bone scan. The PSA at baseline was 151. About 3 months later, the PSA was 0.03, and the bone scan was utterly clear. So ultimately, what do we need? We do need to identify patients who are going to benefit from this therapy, provide the therapy, manage the toxicity, maintain our regulatory compliance and safety, for which we need education, we need communication, we need preparation and backup, all the things that Steve and Nelli talked about. We need the access to the imaging, both the equipment, the space, the radiopharmaceuticals, and the personnel. And of course, we need time, money, administrative support, quality assurance, and given the status of the radiopharmaceuticals and the equipment, I would say a pan-Canadian approach would be a wonderful place to go. So where are we going? I like to aim with this. Do we have a silver bullet? No. Are there new radiopharmaceuticals on the horizon? Yes. Are the ones we already have impacting therapy? The answer is an unequivocal yes. So, at the end of the day, I would say the sky is the limit.